Dr. Daneshgari, so we've discussed that there is a need to transition from attention to this right side of the bow tie to attention to the left side of the bow tie, transitioning from damage control to prevention. But as we know, physicians aren't paid in preventing diseases. In fact, we're paid to treat disease after it's occurred. So how do you propose that we disrupt the current way that hospitals are paid for treating illness in order that they may refocus on prevention?
So the key word there, Bernard, is Dr. Evenhouse, is the disruption. The current model is heavily invested on the right side of the bow tie, on the disease management. That's why I call it a sick care system. The question is, what are the disruptions that needs to occur to transfer the attention to this side? I propose that the first disruption is that the delivery of the services have to go from a provider-centric, that if you're the patient, you have to come to me as the doctor. You have to follow my schedule. You have to wait until 9 a.m. to come and see me. Or actually, you have to drive about 30 miles to come and wait for half an hour and probably wait for my delays to be seen by 5 minutes. That is a provider-centric. Everything revolves around the convenience of the provider. To a consumer-centric. Consumer-centric means bring all the services that you need at the site where you are at the time of your choosing. Because the health needs and the health events don't wait for my schedule. So that is the first disruption has to take place. To transfer the model of delivery from a provider convenience to a consumer convenience, like every other industry has done, from the grocery to telecommunication to entertainment to banking and so forth.
So it almost sounds like you're advocating for a completely different model of healthcare delivery.
I do. So,
and one where it's no longer the case that a person needs to, say, drive an hour and a half to the doctor's office, wait in the waiting room for 2 hours to see their specialist for about 5 minutes.
Right. Exactly. The first step toward that model, that everything turns from the provider convenience to the consumer convenience, is disrupting the existing physical requirements for meeting. And what I mean by transferring the entire process of care from the time where you would need something or your health need requires something to the time really we need to do a procedure, we deliver this virtually. So I believe in the transformation of the entire process of care to virtual delivery. And the reason for that is, as soon as you turn the attention to there, based on the scientific facts, that more than 90% of the exchange between a consumer of healthcare and a provider of healthcare is exchange of information. The easiest way to exchange this information is to digitize the information. As we have seen with other parts of our lives, as soon as you digitize it, becomes easier to transfer it. We call it democratize the information. As soon as you democratize the information, it becomes much cheaper to deliver it, called demonetizing. So the entire process of care for basically the non-surgical, non-procedure part of the care could be digitized and therefore democratized and therefore demonetized. That's the first step and the disruption in this transferring the delivery of care from the provider-centric to consumer-centric.
This concept of digitalizing, democratizing, and demonetizing healthcare, it reminds me of this recent report that I read where they reported that the second most potent factor in the health outcomes and the quality of healthcare received by an individual is actually geographic location. And it makes me wonder that if healthcare were truly delivered virtually, and this aspect of information exchange that you're describing is done through virtual means that don't require waiting rooms, don't require travel to office visits, then we can serve every patient in a standardized manner. As you know, our rural populations are among the most underserved and lagging in health outcomes. And it seems that what you're advocating for here is something that would help bridge this gap.
100%. I think the advancement of the technology, digitalization of many aspects of our lives, from shopping to entertainment to traveling and so forth, is begging the transformation of our satisfaction of our health needs to a virtual delivery concept. And as you said, as a result, not only we will absorb significant amount of technological advancement that we have made. So I'll give you an example. In an in-person requirement that you have to drive and go and wait and so forth, right? So we can check your blood pressure, your vital signs, your temperature and so forth. There are plenty of tools now that we can send this to your home and you can do that information, get that information, and wirelessly, I as the provider receive on my end without you leaving your home. So this transformation of delivery tools would allow to address shortage of physicians in the rural areas, in an area where it's called the medical deserts. It will completely transfer the issue of the access to healthcare providers and to healthcare, which is one of the fundamental problems with the sick care system, because the accumulation of the physicians within the hospital, brick and mortar, or the clinics and so forth has become the barrier to access for a good portion of our population who live in the rural areas and in areas that is called medical deserts.
Wow, so you're really advocating for technologies at the bleeding edge of medicine. You're talking about remote patient monitoring tools and tools that allow patients to actually perform the physical exam themselves during a virtual visit.
That is true, because again, even if today when you go to an emergency room, rarely anyone examines you. You go to the tube of the CT scan, a bunch of labs run, and physicians increasingly use basically digital information to assess the health needs you have. So it's really the change of this process that would allow this transfer of in-person requirement to a virtual delivery. And not only we can absorb the technological advancement and reach to people who are not living in the close to the buildings where the doctors are, this would also break through some other barriers. To me, this whole process of digitalization, democratization, demonetization will break through several barriers, and I'll tell you some. For example, currently on the sick care model, for conditions such as, let's say, prostate cancer, conditions such as obesity, and so forth, we need the input of multiple specialists. Because at the end of the day, if you as a consumer, you have a condition such as obesity or headache or heartburn, and so forth, you don't care what ologist takes care of them. You want a doctor to take care of it. But from our standpoint, we have to bring several specialists. For example, in the obesity, we have to have a obesity medicine expert. We need to have a nutritionist. We have to have a health counselor, because a lot of obesity relates to the behavior we have toward the food. So in the current model of the sick care, again, on the right side of the bow tie, this will require at least 3 appointments. You know, I'm a urologist. In a prostate cancer patient, if you have 5 questions, they make 5 appointments for you. Yep. Whereas the virtual delivery would allow us to bring all these experts, specialists, under one channel and deliver it to you at the place and the time that you need. So this is the first barrier, or one of the most important barrier that will be removed. Delivery of interdisciplinary care, what we call, means bringing multiple specialists to your place and the time of choosing. So as you could see, not only virtual delivery of care will break through the barriers of the physicality and geography, as you said, is the second most important influence on our quality of our health, but also will break through some other barriers that have made the management of chronic conditions such as obesity, diabetes, cardiovascular very difficult, time-consuming, and burdensome for the consumer.
So it really sounds like what you're talking about is, instead of a patient catering to the needs of the doctor, the physician, driving to physicians' offices to see a single specialist in order to answer one specific question. By the way, I love the adage, if a person has 5 different medical complaints, they see 5 different specialists. I might add to that though, if a person has 2 medical complaints that are specific to one specialist, they'll have to schedule 2 appointments in the current system. And so it sounds like this model that you're advocating for is a little bit different. Instead of the patient conforming to the needs of the physician, it sounds like a group of physicians address the specific needs of a patient. Maybe, for example, a person has GERD, gastroesophageal reflux disease, or heartburn. And so they see their primary care physician. Their primary care physician ultimately tells them to go to a gastroenterologist. Well, this is a lot of headache trying to navigate around all these different specialists. And really, from the perspective of the consumer does not care about what ologist, as you said, they addresses their complaint. They are concerned with their heartburn being managed.
Correct.
They're concerned with getting the best health outcomes without reasonable expense and without reasonable inconvenience.
Right. I'll give you a couple of examples from other parts of our life. It's like for car needs or our food needs. Imagine for our car needs, you take your car to a mechanic or a dealer. They will make 5 appointments because your car is not running well. And they make a diagnosis that you have to see a tire specialist, you have to see an engine specialist, you have to see a electronic specialist, and other specialists that all may refer to why your car is not running well.
I'd find a different mechanic.
Yeah, you at the end of the day, you say, no, I have a problem with my car is not running well, right? Is the dealership job or the mechanic's job to bring those expertise under one roof and deliver your needs. On the food part, right? As you remember, we used to go to a butchery and to the bakery and to different sources, 100 years ago, or if you had to go buy all the element of your grocery separately, right? Now you go to one grocery store and you get your needs. If you have a special need, you want to get a very special type of meat, you go and find them. But for the general concept of your food needs, you walk into a grocery store and you get your needs. And this very much applies to healthcare. So as a part of, again, the next barrier to this concept is the separation of primary care from the specialty care that is happening again on the sick care system. To me, is really there are 2 parts to our health needs. One part that I call essential needs. Essential needs that include what we recognize today as primary care. The urgent needs. I get up in the morning, I have a sore throat or earache and so forth. Or if I have a blood pressure or I have some other chronic conditions, I need the chronic disease management, right? I need an acute help. I need the chronic disease management. I need someone to coordinate between, maybe I have a neurology issue and I have a gastroenterology issue. Someone coordinate this coordination of the care between the different conditions. I need to basically make sure that the medications they give me, they don't interact. So these are all called essential care. And this essential care could be delivered under one roof through virtual delivery of care, right? Again, with the virtual, bring the specialists together under one roof to deliver the essential needs you have, very much like the grocery store. The basic food items you need, you walk into one grocery store and buy them. Then the next level becomes the specialist care. If this essential care delivers that, no, you have a aneurysm in your brain and therefore you need to see a neurosurgeon, the person who's in charge of delivering to you this essential care, who knows you the best now, says, yes, here's a neurosurgeon who has a specialty in delivering or caring for people with the aneurysm in their brain. You're bringing up 2 other components to this disruption.
Yes.
One is the scientific data and common sense shows that when you deliver the care at the natural environment of the consumer, i.e. their home, you can tap into other sources of care and recovery that are not available in the cold, sterile conditions of the doctors and the hospital buildings. People's loved ones around them, the nutrition that they're used to is there, and so forth. These are the byproduct of this disruption pattern. But I will propose that the most important part of disruption is, again, we have digitized, democratized, and demonetized, and delivering the virtual care. You bring the interdisciplinary group of specialists to your point of need. Then out of that interaction, the data is generated. The data about your health condition, the amount of calorie you've spent, the exercise you do. So we can convert the delivery of the care from this very subjective, base concept that, I look at you, I feel how you feel today or not, which there has a value. But as you know, industry after industry has shown that when you transfer the subjective impression of everything to data-driven basically monitoring and management of the condition, then we are opening ourselves to another explosion of understanding the risks behavior that contributes to chronic conditions, such as cardiovascular and obesity and diabetes. As we all know, again, we start with a healthy body when we are born, right? It is that behavior and the lifestyle of us that is exposed in interaction with our environment and our lifestyle basically makes us exposed to chronic condition in our middle ages. So the direction of this going from the right to left, the most standing or the longest standing part of it is that changes into a data-driven model of care. And if I make an example, you made the iPhone example, which I love, because at one point all of us had a GPS on our dashboard and a cell phone in our pocket and a digital camera. Now we have one thing in our pocket. The other good example of that is aviation, right? A short 120 years compared to 2,400 years of medicine we have had in aviation. And as a result, because of this risk mitigation and data-driven management of the industry, we have created the safest mode of transportation. And as a result, I propose that if we do this transformation, it is not impossible to the contrary. It's very possible that we all can live to 100 without burden of chronic conditions. And I know one of the other projects that you are very passionate about, how we transfer this concept of the virtual care into a data analytics and reporting, really give the guardianship team a dashboard to navigate our health through the challenges of life.